Thank you. You've given me an extra 1.5 minutes, I think, so that's fantastic, ahead of schedule. I'm giving the next talk, and the title is How do you translate next generation imaging to conventional imaging for treatment decisions? Here are some disclosures, none really relevant for this talk. Not long ago, we didn't even have any CT scanning 30, 40 years ago, and one of the most common operations in the 1970s was in fact a staging laparotomy, if you wanted to know the nodal extent in, let's say, a lymphoma or a newly diagnosed malignancy. So we shouldn't be afraid of new imaging because it generally allows us to make better patient decisions. This is from the first APCCC meeting I attended in Basel back in 2019, and Stefano really told us everything we need to know. The ABC: A, abandon obsolete imaging approaches; B, be aware of the capabilities and limitations of next generation imaging; and C, consider next generation imaging whenever patient management is to be modified. Don't do the test if it's not going to modify your patient management. Back then in 2019, actually there was a lot of skepticism in the room about PSMA PET. Many people were very vocal. Pete Ost would stand up and go, "Do not order a PSMA PET, it's unethical. You shouldn't misguide your management with this new fancy technique." And now, 6 years later, I think there's a general acceptance that it's a standard of care nicely across the whole range of prostate cancer, and some indications continue to evolve. But I want to question whether PSMA PET is a biomarker. No doubt it is, and too often there is too much biomarker talk because part of the role of imaging is also just an extension of the clinical examination. As we learnt in medical school, more is missed by not looking than not knowing. So biomarker is going to need a lot of time for the PSMA PET data to mature so that we can go back and generate the Kaplan-Meier survival curves and prove the benefit. But as an extension of the physical examination, this is really common sense and clinical acumen, and we shouldn't forget that. So when we have this patient from the PRO-PSMA study, on the right had a normal CT scan, a normal bone scan, so N0 disease, but then on the left has M1A disease. Does this matter? And I think logically this does matter, because if you're considering surgery or radiation to this patient, you're not going to cure them with either of those modalities after you've seen this PSMA PET. So at least you can counsel the patient in a very different way. We had a bit of an intense argument over dinner last night, actually. Can we cure patients with neoadjuvant therapy with metastases on a PSMA PET? And this is not a new technique now. We've been using it for over a decade, and I don't think I've seen patients like this being cured. Not to say we can't prolong their life and improve quality of life with treatments, but we don't cure patients with metastatic disease on a PSMA PET. So the PSMA train has well and truly left the station. In Germany, it left the station 14 years ago. In Australia, we've been using it for over a decade now. And really thanks to Stefano and Ken for leading the charge in now standardising and bringing all the passengers on board from all the different specialties. With longer follow-up, we are now getting good biomarker data. So this is from the PRO-PSMA trial published last year. We looked at N1 versus N0, and at 3 years, if you had nodes on the PET scan, this is in the pelvis, 70% were disease-free at 3 years, compared to only 46% on if you had nodes. So highly prognostic. Whereas conventional imaging, CT, not prognostic at all. And we're going to get more data as we follow up these patients longer and longer. But the more biomarker we get for PSMA PET, it seems that it's good. We also published this paper on more accurate imaging is not stage migration. Is it time to move from the Hubble to the Webb in hormone-sensitive prostate cancer? And the concept here is to move away from the fear around stage migration and increasing sensitivity, because one of the big advantages of PSMA PET is that we increase specificity. And although there's false positives on a PET scan in ribs and other sites or with inexperienced reporters, the false positive rate is much, much higher with CT and bone scans. And we shouldn't forget this. This is a patient from the PRO-PSMA trial. On the left, they had metastatic disease on the bone scan and in the liver on the CT scan, so M1C. On the PSMA PET, no metastases. Now, this patient proceeded to a prostatectomy and had undetectable PSMA at the 6-month follow-up. So we confirmed that the PSMA PET was correct. Can you imagine if you manage the patient on the basis of the scan on the left? When you have false positives, you can't possibly be improving the patient's management. So how common are false positives? And we have very good data from the PRO-PSMA trial for metastases. In the primary analysis, when we considered equivocal findings as normal, there was a 6% false positive rate on CT bone scan compared to 1% on PSMA PET. But in community practices, often nuclear medicine specialists and radiologists report very sensitively. They don't like to miss things. So if they see something equivocal, they generally report it as a metastasis. And if we considered the equivocal findings metastases, 1 in 4 patients, 23%, had a false positive finding on CT bone scan, quite high, compared to 7% on PSMA PET. And I don't think management decisions driven by false positive results can be good for patient care. Then we have a tricky issue of small burden versus high burden when we image on CT bone scan versus PET. And this is relevant because we know in the STAMPEDE trial, 42% had low burden disease on conventional imaging, like the bone scans on the left, and they benefited from radiation to the prostate primary. However, in the high burden disease, there was no advantage to things. But when we looked at these patients, at least in our experience in our centre, many of these patients with low volume disease were driven by bone scan findings, and we found that they're false positive, particularly when we use better techniques like SPECT-CT. And when we looked at the number of metastases in the STAMPEDE trial, as you exceeded 3, that's when there was a benefit. And we think this is potentially in part driven by patients that truly had M0 disease and false positive results. They're the patients that were benefiting. Even if we believe that paradigm, it can be tricky to count the number of lesions on a bone scan. You show it to 3 people, one says there's 5 metastases, another says there's 7. It can be really tricky. I think we can do better with quantitative total volume measures on a PSMA PET. You know, this needs more research, but it's much more objective than a visual analysis trying to count individual lesions. Is this patient suitable for lutetium PSMA? This is a biomarker question. We're doing the PSMA PET using the vision criteria if you're above liver at a site of disease without any discordant disease on CT or suitable. In our centre, we do a lot of FDG PETs, and in this patient, we found a cervical spine metastasis that wasn't seen on CT, wasn't seen on PSMA PET. And this patient actually developed cord compression after being started on carbazitaxel a few weeks later. And this brings us back to knowing the true extent of disease, like a physical exam is good for your patients. Because you might question this patient, do you have any neck pain? And if they do, you may give some prophylactic radiotherapy to this site. So that's an extension of the physical exam. Knowing the true extent, you can manage the individual patient in front of you better, as opposed to the biomarker role, which is selecting the patient for a treatment. I'm not going to talk much on oligometastases, other to say than without imaging, oligometastases do not exist. You don't pick them up on any other technique than imaging, and I think we ought to follow Stefano's A of the ABC and abandon obsolete imaging. We can debate whether treatment of oligometastases is beneficial, but if we are going to go down that paradigm, we need to use the best test to ensure that the disease is oligometastatic. That's PET scanning in 2025. The data for PSMA PET is maturing from a biomarker perspective. This is data from Wolfgang Weber and a multi-centre effort from over 2,500 patients using the PROMISE criteria, and we can see across many different groups from initial staging, biochemical recurrence, metastatic hormone sensitive, metastatic castration resistant, wide risk stratification using PSMA PET. Now, this is retrospective data, but I think we're going to see prospective data sets replicating this data over the next few years. But we do need to have caution for restaging. This is an area where there's only 2 validated imaging endpoints. This is for a clinical trial where you want registration of a new therapy, and there's metastasis-free survival in patients that had no metastases at baseline. That's based on essentially driven by largely bone scanning or CT, and prostate cancer Clinical Trials Working Group, PCGW. These are the only 2 validated imaging endpoints, and these should continue to be used, and we shouldn't base these endpoints on PSMA PET in 2025. We need more work. But this is coming. We're going to have a talk from Mike Morris in the afternoon on PCGW4, so I'm not going to talk much on this, other than to highlight this poster that I presented at ESMO last year, where we looked at 142 paired CT bone scans and PSMA PETs. These were done every 12 weeks as part of a clinical trial. And what we see in black is the overall survival. What we see on the red is the PCGW3 based on CT and bone scan. And around halfway through the trial, the two curves meet, which means that patients were dying before they progressed on a CT bone scan. I think this is probably quite common in advanced castration-resistant metastatic disease. This can't be good, because if you can't detect the progression before the patient dies, you don't have an opportunity to change the patient's management. But if we looked at the preliminary PCGW4 that incorporated the PSMA PET, it can see that it parallels the overall survival almost perfectly and seems to perform significantly better than PCGW3. We need to remember that it's a PET CT. This incorporates still the CT resist. So if you've got a liver metastases progressing on the CT that you don't see on the PSMA PET, this is still progressive disease. But we can potentially, in the future, get rid of the bone scan. So in summary, I think imaging is both an extension of the physical exam, this is often forgotten, but also a biomarker. PSMA PET findings are more real than conventional imaging. We improve both sensitivity and specificity. Conventional imaging has a higher false positive rate findings. These do not improve patient outcome. We've got level 1 evidence from the PRO-PSMA trial on this. Like a physical exam, imaging directs individual patient management, and I don't think it's good to treat patients blindly. However, the biomarker data is still emerging. MF, metastasis-free survival, and PCGW3, they still rule in this domain, but let's collect the data and work together on validating biomarker data. Thank you.